So Plan Your Baby is a telehealth fertility and pregnancy clinic, and we try to help patients nationwide. We have multiple locations where you will have access for the blood draw, for the ultrasound scan, so all of the necessarily monitoring during the treatment from the comfort of where you are based, and that allows us to help you to save not only money but the time on travel. And we do provide a different treatment, starting from non-invasive ovulation induction or assistance with conception, and IVF, egg freezing, and close pregnancy monitoring as well. So if you have questions and you would like to start asking them, please type them in the chat group. Dr. Sami, maybe you would like to say something about the type of treatments and what for the most common diagnosis would be suitable, or how patients can start their journey.
So we have different options for patients and different ways that we can help. Some people, they just want to try and find out what their fertility is like, and they want to do just some baseline tests even before they start trying for a baby. Other people may have tried for some period of time, not necessarily found any problems, or not sure if they have any problems, but they want to see if there can be some tests done just to make sure everything is good, and perhaps maybe even some support to help improve the chances for success. And then, of course, we have those people who've been trying for a considerable amount of time, and they've had difficulties, and maybe have had failed treatments even. And these are a different category. And the treatment options that we can offer, can be just some baseline tests. It can be doing some ovulation induction with some tablets, or it can go all the way to advanced fertility treatments such as IVF, etc. So yeah, there is a whole host of things that we can help with. And in addition to fertility problems, some people, they don't have a problem getting pregnant, but it's more the problem of miscarrying in the first trimester. And these people we can also see and make some investigations, and also hopefully give them some support and treatment and scans and emotional support, holding their hand, etc., which unfortunately, especially nowadays with the NHS, is very much lacking. So for people who are wanting to have that, we can offer it to them.
Yes, no, that's brilliant. We have already a question, so I'll just read it. The lady is 35 years old, and she has been trying to conceive for 4 years, unexplained infertility. Factors both side, female polycystic ovaries and hypothyroidism, and from the male perspective is the sperm shape. They've had a round of IVF successful with 1 embryo, which were Modi twins, and then miscarriage at 14 weeks.
Okay, all right. So that's very terrible for this lady. Long history of infertility, and then finally, once they get to the IVF stage, they are successful initially, which is always exciting, and people are hopeful. And then to have the miscarriage so late of twins even must be devastating. I mean, the fact that the IVF did work first time is a very encouraging sign, I would say, because with their problems, there is an issue with male factor. And the polycystic ovaries, for some women that can prevent ovulation, some women still can ovulate, so I'm not sure about for this particular lady. But polycystic ovaries, hypothyroidism, these are treatable. The sperm shape, it's difficult to fix. I mean, the man can try taking supplements and lifestyle changes, diet, and trying these things may improve the sperm, or it may not. So if the sperm isn't really getting any better, then yes, IVF with a procedure called ICSI, where the sperm will be selected under the microscope and the best looking sperm will be injected inside the egg, would be the best way around this issue. And because she's still quite young, she's 35, with IVF, success rate should be pretty high. Not guaranteed, unfortunately, but pretty high. And this lady was initially successful, but I think she was unlucky. I mean, she had twin pregnancy, and twins, most of the time they do well, but unfortunately twin pregnancy is also a more risky pregnancy. And especially if it's a monochorionic twin, which is maybe what I understood, then that's even more of a risk in that pregnancy for problems. And very sadly for this lady, she lost that pregnancy. So you know, it must have been a very difficult situation for you, and I can't imagine how hard. But there is positive to take away from it, and the positive is that you did get pregnant first round. I hope that you have some frozen embryos because that will make it much easier and perhaps cheaper going forwards for you to try again. Hopefully you should try again, try a single embryo, and hopefully this time it will be a single pregnancy, which will be a less risky pregnancy, and it will have much higher chance for going all the way. But I don't think that there is any other specific advice that I will give apart from, you know, trying it again. And hopefully next time we'll get luckier. It just sounds like really, really bad luck, unfortunately, for this lady.
No, thank you so much, Dr. Sami, for such an open answer. And we have another question. Do Bunny Baby offer for recurrent miscarriage investigations, and do these differ from recurrent miscarriage clinics? She is 37 years old, and they've been trying for 3 years. Diagnosed with PCOS but no cyst, have been seen recently on ultrasound scan. So, and she had 2 early losses for her, and recently had a 3rd loss and at 12 weeks and 5 days.
Okay. So yes, we do offer recurrent miscarriage screening and support as well. Now, this lady has had 2 very early miscarriages, but the last one very sadly ended much later, 12 weeks, which is not common. It's not common for the pregnancy to stop at that stage. Now, I would hope very much that she was offered to test the embryo's genetics, because it's possible, especially when the pregnancy ends at such a late stage and the baby is quite big, it's possible to analyze the genetic makeup for the baby to find out if this baby had a normal genetic makeup or not. Because if it had a normal genetic makeup, then that really does bring into question why would you miscarry a normal embryo, and it will really kind of make us think that there must be some issue with the environment, i.e. the woman's body and health, which has caused this pregnancy to fail, and this is something which would then need a lot more investigation and focus. However, if the embryo was found to be genetically abnormal, then this would be an explanation for why the pregnancy was lost. And yeah, it could just be bad luck. I mean, she says she's 37, so at 37 years of age, about 50% of embryos are genetically normal and 50% are genetically abnormal. And those embryos which are genetically abnormal, most of the time your body will reject such an embryo and you just don't get pregnant with it. But sometimes you can get pregnant with such an embryo, and then usually you'll miscarry. Most of the time it'll be early within the first few weeks, but it can sometimes be later on as well. And I have seen some women, I feel, where the natural mechanism which stops these abnormal babies from being accepted and from implanting fails, and they pick up these embryos very easily, and they end up with lots of miscarriages with abnormal embryos. So I'd say, you know, I really hope that she has had some genetic screening offered to her, because even on the NHS, they should offer this. If not, well, I mean, unfortunately, you know, we can't do anything about that. And we would still, you know, offer screening tests before she starts trying again. So I would offer things. I mean, we'd have to see what's been done already. We don't want to repeat things which have already been done, but certainly checking thyroid function, prolactin. And for this particular case, I would probably recommend doing an immune profile to see if there's any immune activity which is too high, which could also then be affecting the embryos and leading to this miscarriage. Hopefully this lady is able to get pregnant herself naturally, so in which case, once we have the results and we've made a plan, we would just kind of wait for her to get pregnant, and then once there is a pregnancy confirmed, we would be able to monitor the pregnancy. We should monitor it right from the beginning. So as soon as she has a positive pregnancy test, she would need to let us know. We would do initially for the first 2 weeks frequent blood tests for HCG, which is the pregnancy hormone, to see the rate of rise and give us an indication as to how the pregnancy is progressing. And we will check the progesterone as well, and we would give additional progesterone. For 3 miscarriages and above, I would also give blood thinners. So I'd give aspirin, baby aspirin, and also a blood thinning injection, a heparin injection as well. And then from 6 weeks to 12 weeks, we can do weekly scans to assess how the pregnancy growth is happening and the heartbeat, etc. And we will also keep checking the progesterone. And if necessary, you might need to do further immune testing and checking the thyroid as well during the pregnancy. And the pregnancy monitoring will be intense for the first 12 weeks. And then once we get to 12 weeks, hopefully, if everything is good, we can kind of tone it down slowly, and the risk of problems after that do become much, much less. But I really hope that she's done a genetic analysis for this last pregnancy. It would be extremely useful to have that information.
Thank you so much, Dr. Sami. I'm sure she will be very thankful for such an open answer. And if you have more questions, please ask if you feel like that Dr. Sami didn't answer some of the things you wanted to hear. We have another question. The lady is 35, turning this week, and herself and the husband started to trying for a baby last November, got pregnant after 2 months, all the typical symptoms, but unfortunately a 12-week scan, they were told that the pregnancy result as a miscarriage ended, and she started to follow the healthier diet, both of them not smoking, not drinking, active, acupuncture, counseling, and supplements. She got pregnant in February after one period, but unfortunately had a blighted ovum. That was diagnosed at 8-week scan 2 weeks ago, and they have they've had a consultation, and doctor suggested aspirin and progesterone if she gets pregnant again, and she's very worried, and it's an immunology issue she's thinking underlying, and terrified that it will happen again. She lives in Ireland. Again, Dr. Sami, anything particularly you would recommend for this case?
All right. So yes, again, this lady, it sounds like she's getting pregnant very easily, but sadly, unfortunately, she's lost both pregnancies that she had, and it's not possible to know the reason why you've lost a pregnancy depending on how early or late it happened. So even if one goes much further and then the others have happened earlier, they could still be for the same cause. So we can't tell what the cause is by the duration of the pregnancy. If it's a first trimester miscarriage, that doesn't really help. But this is something that could be an immune problem, yes. It's not the most likely thing. The most common is still a chromosome abnormality. It's something that can happen to people twice in a row. And, like I did mention earlier, some people do unfortunately have a tendency to pick up these abnormal embryos. It's not common, but, I've seen it quite a few times where I feel that this shouldn't be happening. These embryos shouldn't be picked up, but it can happen. So it could just be bad luck. It could be low progesterone and not enough progesterone. Which could then be something which is easy to support with some extra progesterone. So yes, I would agree that some progesterone and aspirin is probably a good idea. But I would also suggest, doing some extra testing. So once you are having a pregnancy, as soon as you find out you're pregnant, doing some testing on your HCG levels, see how they're rising, checking the progesterone to make sure you're having enough progesterone, and even with the additional progesterone, are you absorbing it properly? Do you have the right dose, the right type of progesterone? Because everybody is a little bit different. Every pregnancy is also different. And these are things that, may support the pregnancy better. But of course, at the end of the day, if the embryo is genetically abnormal, then that's not going to help. Even if you have immune testing done, which is very expensive, and the immune treatments are also quite costly, if the embryo is genetically abnormal, that's not going to help either. So it is something which unfortunately nobody can guarantee, but I would still say for this lady with just 2 miscarriages, that there is a good hope that next time she'll do better. And the statistics do show that if you've had 2 miscarriages in a row, and there's no issue found on your initial tests, then you are looking at 60 to 65% likelihood of having a live birth next pregnancy. And that's even if you don't do any different treatments, no extra support. But of course, I understand that sometimes this can be scary for people, and they've already had 2 losses, and maybe she might feel like she wants to do a little bit extra in terms of testing and taking some progesterone and aspirin, and maybe even some other levels of testing. That's always an option. And I think, Marie, we can help people in Ireland, and we can get a lot of the tests done locally, which we can then follow up. So it's something that if you want, we can see if we can give you a hand if you are pregnant again. Yeah, that's something that we can hopefully help with.
Yes, no, absolutely. The medications can be provided, and if the immune test needs to be done, so that's also can be done from Ireland. Gosh, it's just so common, isn't it, miscarriages? And when you start to hear what
Yes,
people
I
go
mean,
through, it's really
people don't
hard.
talk about it openly. For some reason, there's a bit of taboo about it. So in society, people just don't chat about it. Although, if you do kind of get people to open up, you'll find that so many people have had miscarriage, they just don't mention it. which is a shame, I think, because it makes people feel that a bit isolated, or, why is it just me? I'm a bit unique. But it's not actually like that. And 20 to 25% of pregnancies do end in miscarriage, and it's just such a high statistic that people don't realize that it's so common when they're first pregnant.
That's really huge numbers. We have another question. Dr. Sami, does ICSI increase the chances of birth defect? And some articles supporting this, but the lady is saying that during the consultation, when it's just not mentioned to the patient.
So, I mean, this is something which isn't 100% confirmed yet, but there have been some studies that show there's an increase in some types of congenital abnormality in the baby. So congenital abnormalities are structural problems, things like cleft lip, cleft palate, heart defects, gastrointestinal defects, etc., some structural problem. And the background risk, so for someone who's getting pregnant naturally, is also quite high. It's about 4% risk of a congenital abnormality with a natural pregnancy. When you look at ICSI and the studies that have been done that show there's an increase, it's about 5.5%. So it does increase it slightly. It's not doubling the risk. It's not, extremely increasing it. It's a slight increase. And there have been some further studies which have done which didn't prove this as well. So we're not totally sure. Now, we don't know if this is the case. Is it the ICSI procedure itself? Because when we do ICSI, we are forcing a sperm inside an egg through a needle. Of course, this is not a natural way for fertilization to happen. Is that what's causing it? Or is it because when we do ICSI, we do it usually for men with poor quality sperm, and these men are much more likely perhaps to have genetic abnormalities which can lead to these problems in the babies? We're not really sure which one it is. We're not really sure if ICSI is for sure increasing the risk of congenital abnormalities. It's still things that we hopefully will learn in the next coming few years.
Thank you. Thank you so much, Dr. Sami. And I guess that's something, isn't it, that the consultation should be mentioned to the patients so they are aware of this information.
Patients should be aware, but they should be aware that it's not for sure, and it's not a massive increase. ICSI is not new now. ICSI started in the early 90s, and millions of babies have been born from ICSI now, and some of whom are adults already. So, it's not like when they first started with ICSI and we really didn't know how this was going to affect the babies. At least now we have that background to give reassurance as well.
No, thank you so much, Dr. Sam. And so we have the lady who asked you first question, and she sadly had a miscarriage at 14 weeks. She is saying that she has one frozen embryo, good news. And originally they were told that they will have ICSI, but however, the egg collection, both egg quality and sperm quality was suitable for IVF, and they just waiting the genetic results from the placental tissue. So that's good
That's good news. That's good to hear. So hopefully you get the result, and then that will give some answers. If it does come back showing a normal embryo, though, I would encourage this lady to kind of pursue some additional testing before putting back that frozen embryo.
Yes. And we have another question. The lady is 32 and they have infertility, had ICSI and got pregnant the first time, but at 21-week scan, severe anomalies were identified. And unfortunately, oh gosh, very sadly, that she had to terminate the pregnancy at 23 weeks. And they have frozen embryos. And Dr. Sami, would you recommend to test the embryos if the next treatment will be unsuccessful, or do another IVF cycle? She's saying the genetic test came back normal when amniocentesis were done. What would you recommend in this situation?
I would say that for this situation, no, the testing unfortunately is not going to help you, because the fact is that your baby, even though it had these abnormalities, unfortunately, but the genetic makeup for the baby was actually normal. And if you were to test the embryo, it wouldn't give you any indication that this would have been, happening to your baby, and you'd still have replaced that embryo. So there is no advantage to doing genetic testing in this situation. It's very, very unlucky unfortunately. You just got really unlucky with the embryo that you had and the baby that you had having these abnormalities. It's not common, thankfully. You know, these kind of things you see very rarely, not commonly. And you know, I mentioned earlier, even with natural pregnancy, it's about 4% risk of congenital abnormality, which probably is more than what people think. But you know, we shouldn't dwell on this, because actually most likely, if you were to do the treatment again and to get pregnant again, most likely this is going to be a healthy pregnancy. Unfortunately, there's no way to further prevent it, but you know, the likelihood is that you just got unlucky this time, and 96% next time it will be a healthy baby once you're pregnant. And you know, I'm sure it will be an anxious pregnancy for you next time up until your anomaly scans. But hopefully, you know, you should take reassurance that the likelihood of this happening again is extremely slim. It was just probably very, very bad luck and a very horrible situation to be in.
Dr. Sam, could I ask you, just so we explain a little bit, why congenital abnormalities are happening and what is the cause?
So, I mean, there are genetic abnormalities. Now, they are things that could be related to aneuploidy. So aneuploidy is having the wrong number of chromosomes, and things like Down syndrome, Edwards-Patous, all of these are aneuploidies. And these are things that we can test for easily by doing the PGTA, pre-implantation genetic testing on embryos before we transfer them. And you can identify with quite good accuracy if the embryo has aneuploidy or not. However, congenital abnormalities can also happen outside of aneuploidy due to other genetic deletions, translocations, etc. And these are not easy to pick up, and you cannot screen for them unless there's something which is you know, part of a recurrent syndrome. So, you know, if there is something which it looks syndromic, which, you know, from the post-mortem and from the pathologist's report, they would suggest further testing on the parents. Actually, this is rare. Most of the time, it's just a bad combination, bad luck, and they will tell you that, you know, there's nothing that needs to be done differently. It was just bad luck, and hopefully next time, fingers crossed, she'll be okay.
Thank you so much. And we have a few more questions, Dr. Sami. The lady is 44, had 2 miscarriages from the natural pregnancies, and she had 7 IVF cycles, and now no positive ovulation using clear blue digital sticks. So can HRT boost her estrogen, or what can she do in this situation?
Okay, so yeah, very sad for this lady. She's had a lot of IVF, unfortunately, and she says she's not having positive ovulation, but you know, I wonder if she's having regular menstrual cycles. That's probably more important. If you are having regular menstrual cycles, then that's a sign that you are ovulating, even if the clear blue or whatever stick you're using doesn't pick it up. Sometimes they do give false negatives. This fact that the cycle is coming regular, you can predict your cycle within 2 or 3 days, is a pretty good sign that you are ovulating. And you could do some further tests, you know, blood tests, etc., to confirm this. But it sounds like this lady is asking about HRT. Now, HRT, it's given to women who are kind of in the menopause or perimenopausal state, and their estrogen levels are constantly low. They're not having cycles. And it's to replace that natural estrogen, which is important for the woman's bone health, cardiac health, etc. And usually HRT is recommended up to the age of 50 for someone whose periods have stopped earlier on. Now, HRT is not going to help in trying to get pregnant. In fact, if you're on HRT, it's going to suppress ovulation. It's going to suppress your ability to get pregnant naturally. So it's not given to people who are trying for a pregnancy, whether naturally or through IVF. So no, HRT isn't the solution here. I would say, you know, if she's having regular cycles, she probably doesn't need to worry too much, and she could, if she wanted, do, you know, a progesterone test and scans and things to see if she's ovulating, which I expect she is, and she'll still have the chance to get pregnant naturally. But HRT is not going to be something helpful for her if she's trying for a baby.
Thank you, Dr. Sami. And so, Dr. Sami, the lady is asking what would be the success rates for woman who is 36, low AMH level is 3, and endometriosis, and do you do collections and embryo transfers yourself?
Okay, so yes, I mean, the success rates for IVF, they are dependent on the couple. So it depends also on sperm and other factors. So we would always kind of want to get all the information before we give a success rate, a complete success rate. But in general, for women with low AMH and age of 36, endometriosis as well, then you probably would expect a success rate between 30 and 50%, somewhere in that range. But to be more specific, kind of, you'd need to get all the blood results and the information and the sperm side of it as well. I do egg collections myself, but through Plan Your Baby, I work remotely. So the egg collections and the embryo transfers are done through our partner clinics, which are currently in London. And the doctors there will be doing them, and they are, you know, experienced doctors, not trainee doctors, who will be doing it for you.
Thank you. And so Dr. Sami, do you offer multi-cycle packages for embryo batching with PGTA? The lady is 42 and have had one failed cycle recently, and she had immune treatment as well. She has adenomyosis, endometriosis, low antral follicle count, and elevated cytokines and natural killer cells.
Okay, so PGTA is when we test the embryo's genetics before we put any embryo back, and it will involve, first of all, going through a cycle of stimulation, getting the embryo biopsied, where we put a needle in it or remove some cells from the embryo, and then we have to freeze this embryo. We cannot transfer the embryo in the same cycle because it will take a couple of weeks for the genetic result to come back. And then we can select from the embryos which of them are genetically good, and we will keep those, and the ones which are genetically abnormal, we throw them away because they have little benefit to us. Now, the main problem is age here, and as you get older, the proportion of embryos which are going to be genetically healthy are going to be few. So at 42, we're looking at probably around 25% of the embryos being genetically healthy. Now, that doesn't mean 1 out of 4 are going to be healthy, of course. This is a statistic. So let's say, for example, that we get 4 embryos. It could be that 1 is normal and the 3 are abnormal. It could be 2 are normal. It could be that none are normal as well. You can get lucky, extra lucky. You can get unlucky as well. And I've seen that before, which means that sometimes people do have to go through another round to get that normal embryo. But I would say once we get the normal embryo, then we probably shouldn't need to do more cycles, and we should focus on the other side of things. For this lady, it sounds like she has immune problems. She has the cytokines being raised, and if the cytokines are raised, then this will need treatment with medication. It will take some time. It could be that you can kind of pair the treatment of the cytokines with going through the stimulation. I would say probably that's a good idea for this woman to take the treatment for the cytokines, which takes 2 or 3 months, and during that time make the embryos and get them tested and get the results, so that hopefully once the cytokine treatment is done, we can kind of just get cracking and deal with the other side of things as well. But I don't necessarily push for batching, where you are kind of tied into doing 3 cycles, and you may get enough embryos from the first cycle. You may be extra lucky, you get 2 good embryos, and why do you need to do another cycle or another 2 or 3 cycles? I don't really see the need for that. I mean, it's possible, it's an option, and if we don't get good embryos, then that will be probably what we recommend, but it's not something that I would say we should tie in from the beginning. I think we should probably go cycle by cycle.
Thank you so much. Thank you, Dr. Sami. We just have another question from a lady who had miscarriages and asked you before. But now, this particular question is about the thyroid function test and TSH, which we know is extremely important to test even before the pregnancy. So the TSH level is over 2.5, but still within the normal range. For NHS, they say it should be between 3.5. So is this okay for pregnancy, or would you recommend this level be brought down through the medication, like by taking medications?
Okay. So TSH is thyroid stimulating hormone, and there has been a lot of research over the last 15 to 20 years, some of which has shown that if the TSH is above 2.5, this can reduce the rates of conception and also can increase the risk of miscarriage. There have been counter studies which say no, that's not the case. As long as it's below 4.2, some studies have said it's fine. But to be honest with you, TSH testing is quite easy, relatively cheap. and also the treatment, which is thyroxine. These are thyroid replacement hormone tablets. Again, it's quite easy to take. You just take it once a day. It's a tablet. Again, reasonably cheap. So in my opinion, it's not something that should be ignored. It's quite easy to treat and bring the levels down to below 2.5. And I would always aim for that before starting treatment or before someone's trying to conceive naturally. And then make sure that, you know, when they're pregnant as well, probably to repeat the thyroid function test because it can change, especially with pregnancy. And if we need to tweak that dose, then we can do as well. So I would prefer to treat it. I won't say that if your TSH is 3 that you're going to definitely have a bad outcome, because I don't believe that's the case. But I do feel that it's better to tweak these things and get the body in the best state possible to hopefully give the best chance going further forwards, especially for someone who's had, you know, difficult history, they've had current miscarriage or, you know, difficult time getting pregnant. You know, I really don't see the need to skip something simple like this.
Thank you, Dr. Sami. And thyroid function test, it's broadly available, and it's quite an easy test, and results usually reported the same day. We have another question. Lady is 41 and very sadly she had 3 pregnancies and losses and 1 TFMR, and then due to chromosomal abnormalities, 1 miscarriage at 6 weeks and 1 missed miscarriage at 8 weeks, again due to chromosomal abnormalities. All recurrent miscarriage tests were fine, and she's been advised to keep trying, and hopefully she will achieve the pregnancy and it will not result in miscarriage, but the statistics show that she probably expects to have 50% of the pregnancies produced abnormal. And is there anything, Dr. Sami, that actually you can take, like supplements or vitamins to help prevent miscarriage?
Okay. You said she was 41, is it?
Yes.
Yeah, okay. Right, so yes, very sad for this lady. She's had recurrent miscarriage, and it looks like the ones that have been tested have found to be genetically abnormal. And that is the commonest cause of miscarriage. And as you get older, unfortunately, the chance of the embryo being abnormal is higher, and therefore the chance of miscarrying will be higher and higher each year. Now, sadly, as you know, as you all probably know, you don't make eggs. Women don't make new eggs, and these eggs were in your body even before you were born. And as you get older, especially as you go beyond the age of 35, the quality of the chromosomes, the DNA, will start to break up, and this will then lead to a higher likelihood of abnormal embryo, and therefore lower chance of pregnancy, higher risk of miscarriage, etc. People do try lots of things to improve egg quality, and you will find, you know, there are books and people giving talks and supplements and saying, you know, improve egg quality, improve egg quality. The fact, unfortunately, is that the main thing that we talk about when we discuss egg quality is the genetic makeup, the chromosomes, because this is the most determining thing. It's more important over everything else. You know, if your chromosomes are abnormal, then who cares about the other factors of egg quality, because the fact is that that embryo is not going to be a good embryo for you. And unfortunately, you cannot fix an embryo which is, an egg which has gone bad, because that egg is not going to be fixable, not with hormones, not with supplements, not with diet change. Nothing will replace the DNA and fix it and make that into a good egg, which will give you a good embryo. So that's something which cannot be changed. However, you still can try things to help other factors to do with egg quality. So things like the energy production, the mitochondria, you know, other things. These can be helped with lifestyle, so improving your diet, keeping yourself in the best health, reducing toxins like alcohol and smoking, taking antioxidants, and something like CoQ10, coenzyme Q10, has been shown in some studies. So these can help with that side of it. It won't fix the chromosome problem, which for this particular lady probably is the main issue. Now, it depends, of course, on her and what she wants to do and what she can do. And also it will depend on her, how good her egg reserve is currently. But one option could be for her, rather than, you know, facing the issue where she can get pregnant again and again, and unfortunately the embryo can be bad and she ends up miscarrying. So one possible option for her to consider would be to go through IVF treatment, and then have the embryos genetically analyzed, PGTA, which we mentioned before, And then they can see which of these embryos are genetically good. And if she's lucky enough to have a good embryo, then this embryo will be transferred, and hopefully she will have a much lower chance of miscarriage. So for genetically tested normal embryos or healthy embryos, the chance of miscarrying is about 8% only. So it still happens because there are other reasons of miscarriage, but it's a much, much lower risk of miscarriage compared to, what she would have if she were to get pregnant herself naturally without that testing. Unfortunately, of course, IVF is very, very difficult. It's very expensive, and it's not even guaranteed to work. So even if you transfer a genetically healthy embryo, it's about 50, maybe maximum 60% of these embryos will actually result in a pregnancy. And I've seen it before where people have done the genetic testing, been excited to have the genetically healthy embryo, they transferred it, and they didn't even get pregnant, and they get angry because they were able to get pregnant naturally themselves. So, a lot of things to bear in mind and think about and discuss, but it is something which some people in her position would choose to do.
Thank you, Dr. Sami. We have another question. Lady did IVF cycle last year, and it was a healthy embryo, but the implantation failed, and she already has 2 children before by natural pregnancy, but for the 3rd time, the conception is just not happening that easily, and and she had also miscarriage at 7 weeks, and she's 34, and AMH 1.19. What would you recommend for someone on the younger side with a low AMH? And
okay, so this lady managed to have 2 children naturally, and it sounds like probably easily. And then she did IVF with a healthy embryo. I'm not sure if healthy embryo means it was genetically tested and found to be healthy, or just it looked okay under the microscope, because that's, of course, quite different. But in any case, it didn't implant. And then she had a miscarriage as well. Now, especially if you transferred a genetically healthy embryo and it didn't succeed, or she miscarried with that, then I would say immune problem is probably top of my list, because the immune system can change. And, she's had 2 babies, I know already, but sometimes the immune system can activate, and then it can make future pregnancies more difficult, or more difficult even to get pregnant in the first place. And if you have an embryo transferred which is genetically healthy, we really need to look carefully as to why this embryo hasn't implanted, because the genetics are one of the biggest factors that prevent implantation with IVF cycles. So if she hasn't done immune testing, I would recommend it for her. It could also be, that immune problem is still there, and that's why she miscarried, sadly, this January as well. So yes, I think this is probably something that she should look into. And looking into immunes would involve a blood test. It's quite expensive, and the treatments are also quite expensive as well. So she'll have to think about if she wants to take this route or not, but something to think about and discuss.
Thank you. Thank you so much, Dr. Sami. And we just have a few more questions. In regards of the PRP and of the ovarian rejuvenation, is that something that Dr. Sami, you would recommend, or what are your thoughts about this treatment?
So yeah, I think you're talking about ovarian rejuvenation, PRP for
Ovarian, yes,
yeah.
yes.
Okay, so this is something which is still, again, fairly new. Probably the last 3-4 years it started, and even in the UK, it's not really taken off quite so much just yet. More so available in Europe, I would say. In Greece and Spain are probably the forefronts of where it's being done currently. The idea is that they will take some of the woman's blood, they centrifuge it, they spin it down very fast and separate the blood into layers. And then the layer which has the platelets in it is called the platelet-rich layer. And not only does it contain platelets, but it contains lots of growth factors. It's thought that if you take this layer and you inject it into the ovary, it may stimulate the ovary in cases where the ovaries are being a little bit lazy. So for poor ovarian reserve, this is something that could be considered. And it may help then, after a short break of 6 weeks to 3 or 4 months, that this ovary may be stimulated to produce hopefully more eggs, more follicles, and hopefully if she does the IVF in that period where the ovaries are working better, because it does wear off after about 4 or 5 months. But if she does it within that time, it may be that the response will be better and will be producing more eggs. Now, it's not proven yet. And I have sent quite a few patients to do it where we've really struggled to get eggs. And my own observation is similar to what a lot of people have seen, is that it doesn't work for everyone. It will probably help about 30 to 35%. So about a third of people who do it will see some benefit. I mean, it's not like you'll get from 1 egg to 20 eggs. Maybe from egg you get 2 eggs, or from getting 2 or 3 eggs, you'll get maybe 4 or 5. It will be a marginal increase, but probably still an increase that can give a significant improvement to the next cycle's success rate. So not something definitely I would recommend widely, only for certain cases where the egg reserve is very low. Then it may be something to consider. And it's not easy to get it done in the UK. And even in the UK, it's only just started, so the expertise is still building. So usually I would recommend for people to go to Europe for it to get it done. And there's a colleague of mine in Greece that I know has done hundreds and hundreds of these, that I would suggest you go there for that if you want to do it.
Mm-hmm. No, thank you, Dr. Sami. And we have another question in regards of this situation for someone who had 3 IVF cycles failed, and in which situation, Dr. Sami, would you recommend to continue using your own eggs versus the donor egg treatment?
Well, I mean, there's a lot more to it than just what's been mentioned, because first of all, it depends on the age. If the woman is older, if she's 44, 45, then own egg treatment is going to be very, very low success rate, and donor egg will be so much higher. But if this is a young woman and she's had 3 IVF cycles which have failed and the embryos seem to be good quality, then it's not necessarily the case that changing the egg to donor egg is going to actually give you a better chance. And it may be that you need to look harder to find what's causing these failed cycles. Perhaps it is to do with immunes, perhaps it's the level of support during the cycle and during the, if she's getting pregnant during the pregnancy as well, that's lacking. Maybe it is that you need to do immune treatments. Maybe you need to give more blood thinners. Maybe you need to look at the lining of the womb. Maybe you need to do a hysteroscopy and find out if there's any thing that's being missed inside the uterus. There's a lot more digging that needs to happen first, because I have seen it quite a few times where people have done a few cycles, young women, under 35, they've done 3, 4 cycles in a clinic. They've been told by that clinic, it's not working, you need to do donor eggs. They've actually gone and done donor egg treatment for 2 or 3 cycles. That didn't work either. And then they came back and, it's an immune problem that we treated, and they had baby with their own eggs. So I think you kind of need to figure out what part of the spectrum they're on. And if it is a younger woman, then definitely it may not be the solution. Donor eggs is not always the solution to fix every problem, of course.
Mm-hmm. Oh, thank you so much, Dr. Sami. We have quite a few more questions. Lady, she's 40, have had about 5 IVF cycles and 7 embryos transferred in total, no success yet. What would be the recommendations? And she did have immune treatment in the past, but the treatment didn't seem to have any effect or didn't give any results.
Sorry, what was her age again? I missed that.
She's 40.
40. Okay, so yes, I mean, very unfortunate to have had so many treatments which have failed. Unfortunately, to get the successful IVF, everything has to be right. So if you treat the immunes, but the embryo is genetically abnormal, then unfortunately, that's not going to lead to a successful cycle. If you have a normal embryo and the immunes aren't taken care of when there's a problem there, then unfortunately, the cycle isn't going to work either. So it's important to look at what's been done and the level of treatments that have been offered. As she is 40, at that age, about 30% of the embryos are going to be genetically healthy, so just under a third. And if she's a good responder, if she's producing a good number of embryos, then I would definitely suggest testing the genetics of the embryo before doing any immune treatments and working on that side of it, to make sure that when we actually go through with the cycle and we transfer the embryo, it's for an embryo which is genetically healthy and which hopefully have a good chance of leading to a pregnancy and leading to a successful pregnancy with that, rather than spending a lot of time and effort and money on embryos which we may not know are good or not, and it could just be wasting time and money and effort which we don't really want to waste. So I think, yes, everything has to be right and everything has to be looked at, and if you haven't had genetic testing and you're a suitable candidate for it, if you're only producing one embryo each cycle, then probably not worth it. But if you are producing a decent number, then I would suggest that you look at doing genetic testing just to kind of make sure that when the embryo is transferred, that at least has been ticked off, and we can focus on other things and make sure we look after that as well.
No, thank you so much, Dr. Sami. Another very interesting question about what would be the management for adenomyosis and endometriosis during the IVF cycle to reduce the risk of implantation failure?
So different approaches that can be taken with adenomyosis and endometriosis. One approach which is sometimes taken is for people to be given drugs that suppress the ovaries to switch off the production of hormones, of estrogen mainly. And that's given for 2-3 months, sometimes longer even, before then pursuing IVF cycle. And yes, estrogen does kind of fuel endometriosis and adenomyosis, but it won't make it go away completely. And the problem is mainly with that approach is once you start doing the IVF and once you start getting ovaries to grow, there will be lots of estrogen being produced. And of course, during pregnancy, there's going to be lots of estrogen being produced as well. So, it'll have limited effect, in my opinion. And the big downside to doing this type of suppression is that you get lots of side effects. It takes time, it takes 2 or 3 months, and it is something which can actually lower the number of eggs that you get during the IVF cycle because it switches off the ovaries and can make them quite lazy, especially for someone who's a bit older or who already has low egg reserve. So it's not the approach that I would recommend. Now, one of the problems with endometriosis and also to some extent adenomyosis is that it can activate the immune system. So especially if someone's had repeat failure or repeat miscarriage, I would certainly suggest getting immune testing done, looking at whether or not there needs to be any additional drugs given to try and improve the chance of that cycle working and of the pregnancy being successful. And that sometimes is being missed by people, and they just kind of ignore it, and they keep doing treatments again and again. It doesn't work. Now, not all women with adenomyosis and endometriosis will have this immune activation. I would say about 30%, but certainly with someone who has a history of failed treatments or recurrent miscarriage, I would say that needs to be looked at.
Thank you. So just a few more interesting questions to make sure we will answer them. Dr. Sami, would you offer by default ICSI if there is no male factor issues? Very recently, the reason why lady is asking, so she was recommended this because of her age, she's 40.
Okay, it's a very good question, actually. So in some countries, like, for example, the US and also some parts of the Middle East, ICSI is the only way fertilization is happening. And the US is the biggest market for IVF. They do more IVF cycles than anywhere else in the world by a big margin. So ICSI is the only way that people will get fertilization. IVF is not even on the cards. However, in the rest of the world, and especially in Europe, it's not the case. And IVF is the standard treatment, and ICSI is done for either male factor or for frozen eggs or for failed fertilization with IVF. So there kind of needs to be an indication to do the ICSI. It's not just done for any old reason. And certainly a woman's age, or if a woman just has one egg, for example, that's not a true indication for doing ICSI. That's not an accepted indication. And I would only recommend the ICSI for when it's needing to be done because, first of all, there is perhaps the potential risk. We mentioned it earlier in the discussion today that there is some research that shows there may be an increased risk of congenital abnormality in the baby. There's an additional risk when you do the ICSI because it's an extra manipulation on the eggs. Some eggs, especially for slightly older women, in fact, it may be that the eggs are more fragile. And when you do the ICSI, when you put the needle inside that egg, it may damage the egg. And then you end up with an egg that doesn't fertilize or a damaged egg. Also, ICSI kind of negates the natural selection that happens. So normally there will be lots of sperm fighting to get an egg, and the egg will have a mechanism to choose, hopefully, what's a better sperm, and you kind of negate that. So there needs to be a reason. Of course, for men who have poor sperm, this is the biggest reason. Then you do need the ICSI, otherwise the fertilization rates are going to be very poor, or no fertilization may happen, in fact. So for that kind of situation, yes, but in general, no, I wouldn't do it just because a woman's 40.
No, thank you.
And there's a cost as well. There's an extra cost. It's at least around £1,000 that you have to pay for this procedure. Which if you don't need it, why should you do it?
No, that's absolutely true. Dr. Sami, what supplements can be recommended for the best sperm quality to achieve the better sperm quality?
So for sperm quality, before we mention supplements, the mainstay would be something like diet and lifestyle. And with the diet and lifestyle, healthy diet is very, very important. I would say more important than taking supplements is to have a good balanced diet, lots of fruit and veg, to try and avoid junk food, not too much sugar, etc. Some exercise is very important as well for the man. So sedentary lifestyle is not good for hormones, for his sperm quality either. So exercise is essential, I would say. Avoiding heat, so no hot bath, tight underwear, long distance cycling. Frequent ejaculation, not every day, but every 2 or 3 days is good for the sperm. Making sure the man does get some rest, so some sleep at night, and he's not being overworked or overstressed and exhausting himself. And then we come to the supplements, and the supplements, you don't need to go crazy with the supplements. They are kind of topping up what's there in the diet. So the diet is always going to be mainstay. But you can get supplements which are not too expensive and widely available, things like Boots' own brand male fertility supplement or Wellman Conception. They're pretty good, I'd say. They cover pretty much all you need. In addition to that, the man may need some vitamin D, especially if he's found to be vitamin D deficient. And if he doesn't eat much fish, I would probably suggest an omega-3 supplement as well. But certainly there doesn't need to be a list of 15, 20 supplements that this man is taking. That's not essential.
Thank you so much, Dr. Sami. And we just have one last question, if you don't mind. The lady is 41 and she's planning to have a baby with a sperm donor. She has been suggested to have ICSI treatment, and again, going back to you to the previous question, usually it's recommended for the male factor infertility. Now, in her case, she actually chosen to have IUI treatment, and just to answer the question, with the donor sperm, usually the quality of the sperm should be suitable and good to avoid ICSI treatment. And what are the main reasons for which ICSI is preferred to IVF? I think you've answered this question, but maybe if you could comment on IUI treatment and the success rates of IUI treatment.
So yes, I mean, first of all, we'll talk about the donor sperm. So with donor sperm, when you are selecting donor sperm, it will have on it a kind of a label. It says this is suitable for IUI, this is suitable for IVF, this is suitable for ICSI. So if the sperm is ICSI grade, if it is not really up to scratch for IUI or IVF, then you shouldn't do anything but ICSI with that sperm, otherwise the fertilization rate is going to be poor. However, if the sperm is good grade, if it's suitable for IUI, then you should be given the choice. Now, also, it will depend on where this lady's clinic is. If she's in the US or if she's in certain countries of the world where they only do ICSI, then she may be a little bit stuck there, and that's the only procedure that they do. And I wouldn't want you to then force your clinic to make you do IVF when they're actually not set up for it and they're not familiar with it, because they may just end up making more of a mess of it than necessary. So if you are in a clinic where they don't really do IVF, then perhaps you're stuck there with doing ICSI. But otherwise, if they do IVF, then I don't really see why they should be just offering you ICSI for no other reason. Now, IUI is another option. So for single women who've not really tried for a baby and fallopian tubes have been checked and found to be not blocked, then IUI is a much easier, cheaper, simpler solution, where at the right time, sometimes you don't even need medication. You can just ovulate naturally, and at the right time, the sperm will be injected inside the womb, and then it will have to swim up the tube, of course, and to meet with the egg. So it kind of is trying to mimic the natural conception, which this woman, doesn't have the chance to try. But of course, because it is a simple procedure, it doesn't overcome a lot of issues that the IVF will. So with her age at 41, success rates with ICSI or IVF would be usually around 20 to 30%, depending on the clinic. But when you're talking about IUI, I would say between 5 and 8% is probably likely per cycle. Now, she may choose, actually, no, I want to do IUI. I want to have an easy treatment. I don't want to involve myself with so many injections. I don't want to be paying a lot of money. IVF is definitely much more difficult, much more stressful, and she may want to be doing that for 2, 3, 4 cycles, and she may succeed. She may get lucky, of course. But also, if she does feel that she wants to do IVF in the end anyway, with the donor sperm, then I would probably say limit yourself to 2 or 3 IUIs at most, 2 or 3 months of IUI, not to spend, you know, a whole 6 months or a year trying IUI and then move to IVF, because at the age of 41, time isn't on your side, and you do want to try and get moving to get benefit from the maximum egg quality and egg number that you can have.
Thank you so much, Dr. Sami. So we are running out of time, and it was really a pleasure to have you all tonight. Again, I'll just repeat, if you feel like we haven't answered your questions, please feel free to email to us. And I've put this in the chat. It's info@planyourbaby.co.uk, and we'll be able to answer all your questions, and we'll come back to you. There will be a recording available of this session if you will feel like you would like to go back and listen Dr. Sami and his answers, and we will also put some educational content on the Instagram so you can watch it as well. Thank you so much, and it's been really a great evening. And Dr. Sami, I mean, every time I listen to you, it's with my heart at peace, because you provide information to such an extent, and you explain things so thoroughly. So I hope that ladies found it very useful.
Hopefully.
Okay. So yes, so thank you so much, everyone, for joining.